Hello and welcome to my presentation. My name is Esmond. I'm a practicing pharmacist in Alberta, and I'm a certified diabetes educator who also has additional prescribing authorization. So this is just a short video that was requested by a class rep. I had heard that COVID had canceled your labs on insulin, which is a shame because diabetes is a really common condition. If you work at a typical community pharmacy, you'll find that you'll be running into people with diabetes multiple times per day, and often they're on insulin. So here's the video objectives. Actually, a class rep asked for a comprehensive presentation on insulin pens, refillable cartridges, insulin pumps, blood glucose meters, and I could probably spend an 8-hour lecture talking about all this stuff. Since I'm in the middle of recertifying for my certified diabetes educator exam, I don't have time for that right now. So I just wanted to do a short video to just quickly go over insulin. However, if after May, which is after the exam, I can do other videos on other topics if there's enough requests for it. This is just a casual and short presentation that I hammered out in one afternoon, so please enjoy. So we're just going to quickly review the pathophysiology of insulin, the ways to deliver insulin, review the barriers of starting insulin, and there are many, and quickly review how to start insulin as well. So insulin pathophysiology. So with normal glucose metabolism, the body needs a constant supply of energy throughout the day to perform its myriad of functions. Even if you're just watching this video, your brain is burning through glucose at 5 grams per hour. And even just sitting there, you're burning through 8 grams of glucose, more if you've had a lot of physical activity this day. So here's a quick quiz question. How much glucose do you think is in my blood right now? So if you took out all my blood, and sifted it out and measured the glucose, how much do you think is in here? So I'll give you a second, you can pause here if you want. But the answer is in that an average 70 kilogram person without diabetes, there's only about 4 grams of sugar dissolved in the blood. So less than a teaspoon of sugar. I'm going to use sugar and glucose interchangeably in this presentation. So, your pancreas is keeping that glucose in a very, very narrow range. It's a very small range. And, that's why sometimes it's so hard to adjust insulin because we're trying to get it in this very narrow range. And, for a person who doesn't have a functional pancreas anymore, it's difficult to keep it in that range. So this is just a visual of how insulin works. So when we're fed, our pancreas secretes insulin and takes glucose and stores it. And when we're not fed, insulin is suppressed, which allows counter-regulatory hormones to break down our our stores, and turn that back into energy. However, you can notice that, we're not constantly having to eat 13 grams of glucose every hour. On a long pharmacy shift, you might not eat for like 8 hours. And it would be super inconvenient to have to stop and eat 13 grams of glucose every hour. So our bodies have evolved these complicated mechanisms to store energy when we're eating and to access that stored energy when we're not eating. Glucose is one of the main sources of fuel in our body. And you need to keep a constant supply of it. Your brain is using energy right now, as are your muscles, and your liver and your muscles are actually a big storage depot for glycogen, which is the main storage form of glucose in the body. So when you're eating, insulin is secreted, you store that glucose as glycogen in your liver and your muscles, and then when you're hungry after like 8 hours of studying and you haven't eaten, counter-regulatory hormones are breaking down that glycogen in your liver and in your muscles back into glucose for your energy and your muscles to be used. So insulin is the key to opening up your cells so that it can open up, take that glucose inside, and burn it for energy. So there's multiple ways to deliver insulin. And they're kind of separated into, there's 5 ways I want to talk about, and kind of a 6th way that may or may not come. Generally, it's subcutaneous, and I'll talk a little bit more about that later. And there's in general, I want to talk about these ways to deliver insulin. So the first one is syringes. So I'm just going to pause the video right now. And so you can see this is an insulin syringe. These are BD insulin syringes. These are about $6 at Shoppers Drug Mart. And you can see here, there's a needle and then the plunger part right here. You can see that it has a 1 mil capacity. I'll talk more about that later. And on the other side, you can see the units going from 10 to 100. So if you were administering or delivering insulin through this way, you would pop those caps, draw it back, inject air into the vial, withdraw your insulin, give yourself an injection, and that would be that. So let me just switch back to the presentation. So this is an older method, but you'll probably still see lots of people on it. It requires pretty good eyesight and manual dexterity because you have to manipulate the syringe into the vial, make sure that you're getting the right dose and injecting it. These syringes come in a variety of lengths and capacities and stuff like that. But something that's important to note is that these are only meant for the 100 unit per mil concentration of insulin. Just like maybe 5-10 years ago, insulin always came in only one single concentration, the 100 unit per mil concentration. Nowadays, with stuff like Toujeo and Tresiba, there's 200 units per mil, 300 units per mil. And so you don't want to get those mixed up because on this syringe, if I drew in with the 100 units per mil, if I drew half of it, 0.5 mils, that's 50 units. But if I was doing that for, say, Toujeo, that's not 50 units, that's 150 units, and that's a big difference. And so I'll talk more about that later, but that's why syringes, while still being used, you can't combine it with the newer insulins. So this syringe is meant for single use only. The needle gets dull afterwards and it's recommended you throw it away, though in all honesty, lots of my patients probably reuse needles, but I'll talk a little bit about why to not recommend that later. And there's actually a form for injection technique guidelines. Just Google that, just Google FIT guidelines. That is a great resource for all things injection related. You can look up needle lengths, you can look up whether you need to pinch the skin or which angle to approach it on, or what to do for different institutions and stuff like that. So I totally recommend that you check it out. It's a great resource. So the next thing I want to talk about is reusable pens. So I'm going to just stop sharing right now. So this is a reusable pen. Okay, you pop that open, and as you can see here, there's a little plunger here where you can click and you can see the insulin dosing increasing. Okay, so how you use this guy is that you snap it off like so. Okay, insulin comes in little packages like so. Just take one out, pop one out. Here's the insulin cartridge. Pop it into here like so. And now you've got a full insulin pen. Then you need a pen needle. They come in various sizes and shapes like so. This one's a 4 millimeter nano needle. As you can see, it's just like so. You peel the back off and then insert the pen in like such. So there's actually, I don't know if you can see this, but there's actually a needle there. And that pierces the rubber cap. And now you can give yourself insulin. So you take off the first cap, then you take off the safety cap, and then you're ready to go. You can dial up your dose, you press, and then you've given yourself insulin. So this is a little bit easier to use because, once you've got the insulin cartridge in, there's 300 units in this one. This is a standard 100 unit per mil. So this has 300 units in it. So there's generally less manipulation. People will probably get anywhere from 30 to 10 days out of this, depending on their insulin dosing. And so there's less manipulation. Also, it requires less eyesight as well, because this part here, you can actually listen to it. See? Can you hear that clicking? So even if I was completely blind, or I had like severe diabetic retinopathy, I could just listen to the clicks and I would know how much insulin I'm giving myself. So that's a cool feature. This one's a 1 unit, 1 unit is a 1 unit increment pen. It does come in half unit increments as well. Those are generally for people who are very sensitive to insulin or for children who need really low doses. And so I'm just going to recap this. So how this works is really, really simple, actually. So as you dial up here, see, as I dial it up, it's actually pushing a piston. You can see that piston extending here. And that is how the pen drives the insulin out. You can see here with the cartridge that there's a rubber stopper here. And that piston just pushes that up and pushes the insulin out. And that's how an insulin pen works. So it's actually really simple, actually. And you can just cap it when not in use. So let me just go back to the presentation. Okay. So yeah, again, those pen needles are recommended for single use only. They do dull after your first injection. These things are the most environmentally friendly option. You just throw out the cartridge each time. And this is probably one of the most common ways that you'll see for delivering insulin. Now let's go to disposable pens. So disposable pens came about because we have this issue that there's lots of different concentrations of insulin out there now. And so insulins like Tresiba or Toujeo only come in disposable pens. You cannot find concentrated Tresiba or concentrated Toujeo in vials or cartridges or anything like that. They only come in disposable pens because the manufacturer does not want people getting mixed up and giving themselves an overdose. And they're very similar. Let me just pause the presentation here. Okay, so here's a disposable pen. Very, very similar to the reusable pen. Same kind of clicking mechanism and everything like that. The only difference is that this one, I can't change the cartridge. Once this cartridge is exhausted, you throw away the entire thing. You can't reuse it or anything like that. And so it's a little bit less environmentally friendly, it's plastic, but otherwise it's exactly the same as a reusable pen. Let me go back to the presentation here now. Okay. So insulin pumps, those things are much more complicated, but they give you much more control. So basically what it is that you have a device that uses the same piston system as the reusable pens, and it's slowly pushing insulin through an infusion set that you keep on all day. Usually you have to change those infusion sets every 72 hours or so. And you only use rapid acting insulin for insulin pumps, but you can set the basal rate as low as 0.025 units per hour. That's just not possible with an insulin pen. Like with this guy here, the lowest you can do is a half unit pen, which is 0.5. And generally insulin pumps are usually used for people with type 1 diabetes. What's interesting is that newer models can actually link up to a continuous glucose monitor. So, for example, the Medtronic can link up to the Guardian system, which is a continuous glucose monitor that you have on your skin as well. And if the glucose monitor senses that your sugars are dropping too low, it'll send a signal to the pump to automatically shut off. So that's really cool. That's like an artificial computer programmed pancreas that you have there, something that you can just program with whatever parameters you want, and then kind of leave it to do its own thing. I'm not going to go through insulin pumps much here because I've got already a bunch of insulin pump videos on my YouTube channel, and you can check those out for more details. So something to note that all those delivery methods that I've talked about are subcutaneous, meaning that you want insulin just right underneath the skin, in the fat right underneath the skin. It's not designed to go into your muscles. It's not designed to go into arteries or veins or anything like that. These kinds of insulins are designed to form a depot underneath the skin. They slowly disassociate into monomers, and then that gets picked up for the bloodstream, and then it has its effect. So the needle length matters because if you have too long of a needle, then you get an intramuscular injection, which has erratic absorption. So because you're poking yourself a bunch, you do want to rotate the site. You want to counsel your patients on site rotation. If you don't, what can happen is that there can be what's called lipohyperdystrophy, which is basically a giant fat lump forms in the area if you're injecting the same place all the time. Basically, the skin gets angry at you. But those fat lumps, one, they are unsightly, and two, if you inject into them, they can have erratic absorption. So you want to be constantly using a new piece of skin, rotating the injection site so that you don't form those lipodystrophies. These are the general injection sites. Most people use the abdomen, however. So you can deliver insulin intravenously as well. Generally, that's pretty rare. Even if in the hospital setting, you mostly see subcutaneous injections. I worked in psychiatry at a hospital, and every one of those injections was subcutaneous. Usually, intravenous injections are in emergency, CCU, surgical settings, that kind of things. I just also want to quickly mention inhaled insulin because there was one company that was coming out with a product called Exubera, and they basically put insulin in an inhaler. You would puff it, insulin would be absorbed through the lungs. It didn't come to market, but several other insulin companies have tried, so maybe one day we'll see that. But I just wanted to mention it because it seems drug companies are always trying to find a way of giving insulin without injections because people hate injections. So barriers to starting insulin, and there are many. And it's important when you're talking to a patient who is starting insulin to try to put yourselves in their shoes and try to think about what experiences they've had and to ask them about it. You know, for a lot of my patients, you know, they're 60, 70, 80, their experience with insulin is their own grandparents boiling syringes, giving themselves insulin, going into insulin shock where they're lying on the floor, flopping around seal with seizures because insulin was so variable back then. So that's kind of, when you mention insulin, that's the thought that comes in, that's the image that they see in their head. And so you really want to kind of put yourself in their shoes, ask, okay, what are your fears? And try to address those fears one by one. It's your job to try to reassure them. So here are some common patient concerns. So there's a sense of loss of control, belief that the disease has worsened. So it's important when you have a patient with a who's newly diagnosed with type 2 diabetes, this is type 2 diabetes only, that you counsel them that, you know, your pancreas is retiring. The normal progression of diabetes is that when your pancreas completely retires, you will require insulin at that point. That's a normal part of the disease. You know, everyone wants to retire. Your pancreas is retiring on you as well. And once it retires, there's no other organ that knows how to make insulin. Insulin is the job of the pancreas, and no one else can do that job. So try to frame it in that it's a normal sense of the disease, and it's true. Like if people with diabetes, if they live long enough, their beta cells will go to complete beta cell dysfunction. And at that point, they will need insulin. And so trying to frame that as a normal progression of the disease, not that they failed or they screwed up, or, oh, if you only had lost that 10 pounds, and if I only hadn't eaten all those cookies during COVID kind of stuff, all that self-blame, self-incrimination, you want to try to avoid that as much as possible. So with injection-related anxiety, the best thing to do to reassure patients is just do a dry injection of yourself right in front of them. So this requires, you know, like a private, confidential counseling room. And so if my patients, if injection-related anxiety is a problem for them, I just do a dry injection with one of my insulin pens. You can get insulin pens from drug reps. You can get pen needles from drug reps. They're more than happy to supply all that stuff with you. I just do it through the holes in my dress shirt and show them that, hey, it doesn't hurt. And when they see that a person is, talking to them, laughing at them, showing that, the needle doesn't hurt, that relieves their anxiety immediately. I can see the anxiety just simmer out of my patients. Because, again, they're thinking that this is extremely painful. They're expecting me to scream out in pain when I do the injection. And when they see that, hey, I'm still talking to them, I can barely feel it, that calms them down right away. So if you haven't done this, I would suggest that you do this. Just do a dry injection, no insulin and stuff like that, with one of the reusable pens. You can just so you can take the you can take the cartridge out, put a pen needle on, and then that's not injecting anything into your system. The piston's going up, it's not injecting air into your system or anything like that. And so once you've done it and you yourself can see that it doesn't hurt, then you're calmer, and the more calm you are, the more calm your patients will be. So that's what I suggest for that. Fear of weight gain is a concern. Weight gain and hypoglycemia are the two most common side effects of insulin. Do note that, but you can reassure them in that, hey, you can add on metformin. Like I'm assuming you guys have APA. That by putting on metformin, that tends to lower the dose of insulin needed, which reduces weight, and then metformin itself seems to attenuate weight gain. Also, with a lower dose, usually there's less hypoglycemia, and excessive hypoglycemia usually causes weight gain as well, as because they have to eat a whole bunch of sugar just to bring their sugars back up. For fear of hypoglycemia, you can kind of reassure them that newer insulins have much less variability. We used to use Hyperion, which is pork insulin, and cow insulin and stuff like that. And those are insulins that are similar enough to human insulin that it works, but there was like a whole bunch of variability with them. And that was what caused the hypoglycemia. So you can reassure them that newer insulins have much less variability. Studies have shown that they have much less incidence of hypoglycemia. You can reassure them that, hey, we're going to start you on a really low dose, titrate up slowly, and that should minimize their hypoglycemia. If they lack the confidence to do injections, just set more frequent follow-ups, give them a call, see how they're doing, and things like that. The concerns of family, work, and friends. So in the Diabetes Canada Clinical Practice Guidelines, there is a chapter on driving. And so the guidelines give like a general overview, but the rules for driving, like truck drivers and long distance drivers and hypoglycemia, are different in each province. So you have to check with each province to see what are your guidelines. But generally, as long as you're not having hypoglycemia, insulin won't affect your work. It's just like going on a pill and lowering your blood sugar, and shouldn't have any effect on your work and things like that. Sorry, I forgot this perception that insulin is not effective. So, in the olden days, insulin was this kind of last-ditch effort where basically people, like, their disease was extremely, extremely severe, and then they would put on insulin. So for a lot of my older patients, they remember that their grandma was put on insulin and then they lost a foot, or their grandfather was put on insulin and then they had a heart attack the next month and they died. That's because they started insulin therapy way, way, way too late in those kind of days. You can reassure them that insulin is effective, that we started early now. It's effective in preventing those things, those macrovascular and microvascular complications from happening. And you can, reassure your patients that way. Okay, so this was a study done by Dr. Harris in Ontario. So this is Canadian data. And, even in patients with very high A1Cs, there's this reluctance to start insulin, both from the patients and the clinicians. Clinicians think that it's very time consuming, it's very complicated, they worry about hypoglycemia, and then patients have all these worries about hypoglycemia, needle pains, things like that. And so we call that clinical inertia. And there's all these barriers to increasing insulin. And if even when they initiated insulin, the A1C was quite high, 9.5 at that point. Even a year later, it was still 8.1. And on visit 3, and that's almost 4 years later, the A1C is still not at target at 7.9. So that's where I think we can come in as healthcare professionals, as pharmacists. We can kind of help take over, titrating insulin slowly to avoid hypoglycemia, but to keep patients at target so that they don't have those microvascular and macrovascular complications. Okay, sorry about that. So how to start insulin. So I've covered this in other videos, but I just want to go over 2 resources that I think will be really, really useful. One is that on the Diabetes Canada website, you can find this insulin pen start checklist. And so, you can just download this, and it's great for documenting that you went through something and that you were thorough and went through all the points. And, the first item assumes that you know the patient. If you know the patient, then you don't need to do a cognitive assessment. Generally, if your patient has dementia, don't start them on insulin. But then after that, you just go through the different steps in starting someone on insulin. And in terms of dosing and things like that, in the 2018 Diabetes Canada Clinical Practice Guidelines, in Appendix 9, you can find some starting doses for insulin. I also have videos on that, so please check out my channel and click on videos for that. Okay, so thank you so much for your attention. If you have other video requests or ideas, please feel free to email me at cdestudycourse@gmail.com. I'd have to start those videos after I recertify. But yeah, if you have questions, feel free to ask me. I hope you enjoyed this presentation and found it helpful. Thank you very much. Bye.